This poster is the first result disclosure of our prospective clinical trial in patients with metastatic urothelial cancer, that's cancer of the bladder or urinary tract, who have had their cancer metastasize. It's been treated with a checkpoint inhibitor, and their cancer has progressed subsequent to checkpoint inhibitor treatment. So really what we're looking at here is a population of patients with metastatic urothelial cancer who had developed resistance or refractoriness to checkpoint inhibitor therapy. And we proposed to try 2 agents in combination to try to overcome that resistance. So the question of resistance is still a crucial one in our field. We have a subset of patients who respond beautifully to checkpoint inhibitors, often for a long time with minimal side effects, which is great. But for those that lose their response or never have a response, we're looking to see if we could overcome that resistance. The approach we took in this phase 2 study was to combine Guadecitabine with Atezolizumab. So Atezolizumab being a PD-L1 inhibitor and Guadecitabine being a hypomethylating agent. We combined these two with the hypothesis that what we would achieve would be twofold. One, to elicit this viral mimicry mechanism within the tumor to allow for these tumors to be recognized or re-recognized by the immune system. And the other was that the epigenetic component would reprogram the T cells to overcome exhaustion. And we have in the poster some more details on the background and why we thought that combination would work. So in terms of the clinical trial results, we did tested the combination in the first 6 patients for safety. The combination at the target dose of Guadecitabine and fixed dose of Atezolizumab was tolerable, and so it moved into the second phase of the study. However, once we enrolled 21 patients, it was clear that we weren't going to meet our endpoint, and the study was stopped early. Our endpoint was response rate, so we were looking for actual shrinkage of measurable tumors. We did not have any patients who responded, unfortunately. We did have a group of patients who had durable disease control, meaning their cancer didn't grow during the time they were on study, and that group of patients were considered to be the ones with the better outcome in the study. And it's relevant when we talk about the immune correlates or the correlate studies. And then there was another group, unfortunately, it was larger, who had clinical progression before their first scan. So really pretty rapid progression on study. So one of the things that we noticed clinically in this group of patients was that there was sort of an inflection point when we started therapy, where in some patients, unfortunately, their cancer flared or grew quickly. We are not sure if this is natural history of their cancer or was precipitated in some way by the treatment, but it's something we're investigating closely. So the correlative studies which were embedded in this trial are multiplex, and I hesitate to speak on behalf of the scientists who evolved them, but one was looking at changes in T cell populations and expression in patients before and during treatment, and I'll direct you to the poster for those results. The other was to look at the methylation profiling of tumor tissue before and after. And we did show that pre-treatment and at progression, the tumors were cold, essentially. So probably that's why immune activation didn't really reinvigorate. We are doing additional studies on the group of patients who had very rapid progression on study to determine if there's anything prior to treatment that might have identified these patients for us so that we could prioritize them for alternate therapy.